other procedure. Main outcome measure was intraocular pressure, visual acuity, number of anti-glaucoma medications, complications, and complete success were secondary measures. Phaco was done with foldable IOL, either 2.2 or 2.8 millimeter entry, and Phaco ACPL followed, whereby the processes were targeted at the tip, and whitening and shrinkage was the endpoint. Baseline characteristics were very well matched in both the groups. A follow-up of about a year is available, and in Phaco endocycloplasty group, as you can see, IOP, AGM, and were reduced, and BCVA improved. Sorry. And in the Phaco alone group, it was only anti-glaucoma medication, and which was reduced. IOP did not reduce significantly. When there was a between group comparison, then I found that intraocular pressure and anti-glaucoma medication both were significantly reduced in the Phaco endocycloplasty group, with a complete success of 77% in this group and only 20% in Phaco alone group. Complications that were that occurred were not significant, but I would say significantly there was aqueous misdirection more in the Phaco alone group. Therefore, lasering the tip of the ciliary process, what it does, it aids deepening of the anterior chamber, and therefore I feel that is why we don't get aqueous misdirection. One of the implications of continued usage of anti-glaucoma medications is, of course, continued risk of ocular surface disease, adherence, compliance issues, quality of life issues, and of course, cost implications. And aqueous misdirection has been described previously in Phaco alone group. So I would conclude by saying that Phaco endocycloplasty and Phaco alone procedures are efficacious in lowering IOP and anti-glaucoma medication in mild to moderate angle closure glaucoma. However, Phaco endocycloplasty does it more efficiently. Thank you.
So how many quadrants did you do this endocyclo? How many clock hours?
Yeah, about 2 quadrants. I actually go by number of processes. So we are set to have about 60 to 62, maybe 65 ciliary processes, and I target about 30 to 32. About half.
And what kind of laser settings were used?
Yeah, I start with a power of 500 milliwatts, and I reduce as per pops. My time is fixed at 2 seconds.
So this is endpoint is popping of the...
No, I wouldn't like popping. If I get popping, I do tend to get quite a bit of fibrin post-operatively, and that really does not help. So what I tend to do is, as soon as I get a pop, I reduce the power.
You said aqueous misdirection reduces after endocyclo.
No, what I'm trying to say is that we don't get aqueous. I have, so far in all the patients that I have done, I have not had a single aqueous misdirection, either intraoperatively or postoperatively. And what I have found is that it helps to deepen the AC further. I've done a study on this, an intraoperative OCT imaging.
And how many of patients with Phaco alone had an aqueous misdirection?
3 eyes.
Thank you.
Thank you.